Uh, Good morning to everyone. So today we'll be having a talk on multiple sclerosis. The focus of the topic will be on the role of B cells in multiple sclerosis and what will be the need for starting high efficacy treatment in multiple sclerosis. So this will be the brief content of the topic. It will be for the benefit of all of us, including the residents. So we'll have a brief introduction to multiple sclerosis. What is the disease spectrum in multiple sclerosis? How do you say a multiple sclerosis? How do you assess the disease activity? Some concepts about immunopathogenesis of multiple sclerosis. What is the role of B cells in multiple sclerosis? Why are B cell depleting therapies coming up in a big way? One of which main rituximab we use very commonly all over the world. And what is the importance of starting high efficacy treatments early into disease? So this will be the overall focus of the topic. So we all know multiple sclerosis. We have a neuron, we have the axon, the covering myelin. So it is an inflammatory demyelinating disorder of the central nervous system that is involving the brain and the spinal cord. There is loss of myelin. Whenever there is loss of myelin and demyelination, the electrical conduction is impaired. And the various disease spectrum phenotypes, what we are aware of is clinically isolated syndrome, relapsing remitting multiple sclerosis, secondary progressive multiple sclerosis, as well as primary progressive multiple sclerosis. So this will be how a typical patient with MS, a natural history of a disease will look like. So the main hallmarks here is you can have something known as clinically isolated syndrome, in whom you have a patient coming with just say an optic neuritis or a cerebellar ataxia or a partial spinal cord syndrome. You can have patients after a clinically isolated syndrome having multiple episodes of acute neurological events, each lasting more than 24 hours as per definition. We'll come to it later. Each of this qualifies as a relapse or an event in multiple sclerosis. And whenever there is a lot of relapses, what is seen is that because there is demyelination, the recovery occurs by remyelination, there could be some degree of scarring. So the patient need not necessarily come back to normal. In a typical sense, if you do all the structural and functional analysis, the patient need not come back to normal. And over a period of time, there is accrual of disability. That is, the MRS, though the MRS might remain the same, there'll be minor disability which is accumulating. And whenever that disability is measured by something known as EDSS or expanded disability status scale, and whenever there is progressive worsening of that, we call that the disease has entered into a degenerative phase. So this will be the inflammatory phase of multiple sclerosis. This will be the degenerative phase, where you call it as either secondary progressive. A few subtypes of MS progress right from beginning. So that is what is known as primary progressive multiple sclerosis. And what is seen, very important to note from a pathological perspective as well as from a treatment focused perspective, is that in the first phase, that is the inflammatory phase, the inflammation is mainly peripherally driven. That is, you have some antigenic trigger, the autoimmune cells are triggered in the periphery, they cross the blood-brain barrier. I'll be coming into the subsequent slides. Whereas once it enters the progressive phase, the inflammation becomes resident in the CNS. That is, the inflammatory cells make that focus in the CNS and relentlessly progress, leading on to more inflammation, axonal loss, and neurodegeneration. And this tipping of the scale in which the disability becomes more severe occurs when the cognitive reserve or the brain reserve gets damaged. That leads to more and more disability. So what is very clear is that there could be progression which is starting right from beginning. So this will be the period where you have to act if you want to prevent this progressive phase, especially in secondary progressive MS. There's another in-between entity which has been introduced recently known as active secondary progressive MS, or even some cases active primary progressive MS. That is, some of these SPMS and PPMS could have active lesions in the imaging as well as evidence of disease activity. Those patients are the ones who respond maximum to immunotherapy and should be the focus of treatment. So just to summarize what I told you now, you have the relapsing remitting, you have the progressive MS, you have peripherally driven inflammation here. That is, you have the lymphocytes, the autoimmune cells which enter the CNS through the blood-brain barrier destruction. Then you have new active CNS lesions which are created, and then you have the recovery which occurs by remyelination. You have demyelination, the recovery occurring by remyelination. Whereas once you enter a progressive stage of MS, you have something known as CNS resident inflammation. That is, the inflammatory cells get trapped inside the CNS. They get trapped actually beneath the leptomeninges, according to various pathological studies, and this leads to slow expansion of pre-existing lesions, relentless progression of the lesion, and this is the phase in which you have a lot of cortical plaques, cortical demyelination. The microglia cells which are resident in the CNS also become immune, activated in the immune system. They get activated. All this leads to diffuse white matter injury as well as extensive brain atrophy. So this will be a very important slide for all of us to remember. So there are other types in which you can occur. One, you have focal lesions. The other form, what occurs in progressive MS, is diffuse CNS inflammation. So you have overall in progressive MS, you have brain volume loss, whereas whenever you have a focal lesions, you have what we see in the MRIs as multiple T2 lesions, black holes, etc. So overall, in both focal as multiple focal as well as diffuse disease, you have over a period of time loss of function which occurs, and this can even give rise to motor as well as cognitive problems. Cognitive function in MS is another very underreported topic, but lot of studies are coming up in which they have done morphometry and functional imaging and actually found that cognitive impairment is an important component of progressive MS and needs to be incorporated into the disability scales as well. So what are the phases of immune attack? Immune mediated demyelination, remyelination and recovery. This is the relapse remission. Then you have scarring following repeated inflammation. You have remyelination, which leads to recovery, but this remyelination could be impaired by the presence of scar tissue. And over a period of time, you have axonal damage, progressive disability, which is compounded by the loss of brain reserve. So what is the criteria for diagnosis of MS? Initially, we had the Poser criteria, then here the McDonald in 2010, etc. The latest is the 2017 revised McDonald criteria. For the benefit of PGs and residents, we are just elaborating again that this McDonald criteria is actually more important to categorize a patient to have either definite MS or not to have MS. To categorize either the patient could be having when they come with the first episode, whether it's a clinically isolated syndrome or a relapsing remitting first episode of a RRMS. Very important, it is not to differentiate MS from mimics. Like we do have patients with sarcoidosis and other autoimmune disorders who can come with MS-like episodes. So whenever they come, we can label them as an MS mimic, but it's also important to remember that concomitant autoimmunity can be present in majority of the diseases. Like sarcoid can coexist with MS. At least 25% of such overlap can be seen. And you should know what are definitions for an attack, relapse, exacerbation, CIS, all of which are synonymous. So the latest revision to the McDonald criteria state that you ideally need to have a dissemination in space as well as dissemination in time. But if you have only, you don't meet the criteria for dissemination in time, like you don't have 2 episodes, etc., a CSF OCB can substitute for dissemination in time. And the second revision modification which occurred is that cortical lesions may fulfill the MRI criteria for dissemination in space in addition to juxtacortical lesions. So these are the main revisions. And it's also important to note that the OCBs which we do routinely, that is the intrathecal production of antibodies, are present in more than 90% of patients with definite multiple sclerosis. Disability assessment is something again which we'll have to improve on in not only in patients who are part of research and clinical trials. Sir, pardon me, sir? ADAM around 25 to 30% have, sir, whereas in MS usually it's 30 and it becomes more in the progressive forms. So disability assessment, non-MS white matter diseases like ADM and neuromyelitis optica, they could be present in around 25% ADM. So disability assessment is an important part. It's usually focused more in clinical trials, mainly for outcome measures to say that this one drug is superior to the other and non-inferior, but it's very important to document it. So we have 2 scales here, the expanded disability status score and the functional systems scale. EDSS is what we commonly use. It is mainly based on ambulation, but important to note that you have something known as functional status scoring also. That is your 8-domain FSS. And whenever a patient is ambulant, like a score of less than 4 or 0 to 3.5, it is important to document the individual functional status severity also to comprehensively tell the disability. So that is what we call the expanded disability status score, in which you have points 1, 1.5, 2, 2.5. Until 3.5, we actually have components in which the functional systems are also graded as. So whenever the patient becomes more than 5 or so, they become non-ambulant. So what are the functional systems which are scored? You have 8 domains, mainly a pyramidal system. Each one has a scoring from 0 to 6, some from 0 to 5, 0 to 4. The main systems which are scored are your pyramidal system, cerebellar, brainstem, sensory, bladder, bowel, visual, cognition as well. So this is how an expanded disability scoring is done. The other concept which we should be familiar is something known as NEDA, or no evidence of disease activity. Slowly we are transitioning from a 3-step NEDA to a 4-step NEDA. So as part of a disease activity, the things which you look for is there a clinical event or a relapse? Is there a new MRI lesion or enlargement of a previous lesion, or is there a contrast enhancement of a lesion? And is there a change in the EDSS score which is persisting over a period of 3 to 6 months? So when do you say a patient has a clinical event? We say a patient has a clinical event when there is a acute neurological exacerbation which lasts at least 24 hours in the absence of any fever or active infection. And it's also very important to note that suppose a patient has had just an event 1 month ago, 30 days ago, and has been stable and has the second episode after 30 days, then only qualifies as a relapse. If it's less than 30 days or without a period of stability or improvement, it can also qualify as something known as a pseudo relapse or a pseudo exacerbation. And what is very clear is that all this NEDA3 was implemented mainly when the interferons started or the platform therapies came in initially. So beyond the first 5 to 6 years, the sustainability of NEDA3 was very poor. And with the emerging concept all over the world that neurodegeneration in MS could be occurring very early, they have gone into NEDA4, which incorporates things like brain volume loss, which is measured annually. Less than 0.4% decrement over a year, every year, qualifies as a significant brain volume loss, and the presence of cognitive dysfunction. So this is much more sensitive compared to NEDA3. And in clinical practice, to get these imagings, the morphometry, etc., done will be very difficult. So this can also be replaced by more comprehensive functional composite scores, like doing a 9-hole peg test, PASAT, a 25-meter walk, etc., which could be better than the EDSS. It's very important from a neurochemistry perspective, like to know that there is novel biomarkers which are emerging, like the CSF as well as the serum neurofilament light chain, which is a marker for active disease. So there are clinical scores also, which we'll come to in a subsequent slide. But if a CSF neurofilament done within the first 2 years of disease is able to indicate that this is a marker for active disease, this patient might benefit from higher efficacy treatments very early into illness. So this is a brief pathogenesis of MS. You have both T cells as well as B cells. The T cells get activated in the periphery by the presence of antigen presenting cells. They get activated, they release the pro-inflammatory cytokines, they enter cross the blood-brain barrier. In addition, the B cells also cross the blood-brain barrier. Inside the intrathecal compartment, CNS, these cells get again reactivated. They again produce a lot of cytokines. The B cells go on to form the plasma cells, which form antibodies which attack the oligodendroglיה and the myelin, and eventually there is damage to neurons. So we have 4 stages. One is the activation of autoreactive cells. The second, the crossing of the autoreactive cells, the activated lymphocytes, which include both the B as well as T lymphocytes, which enter the CNS. Inside the CNS and outside, you have activation to T helper cells 1 and Th2 cells, which secrete the cytokines. Then you have the reactivation of immune cells that enter the CNS. Here the microglia, dendritic cells and B cells help in the activation. And eventually there is damage to neurons and the myelin sheath. So why is B cell in MS coming up in a big way? Initially, T cell MS was always considered to be a T cell predominant disease, but with the efficacy of B cell depleting therapies, the focus of B cells and immunopathogens of MS has come up in a big way. So the main 4 actions in which the B cells could be involved in MS is: one, in antigen presentation both outside and inside the CNS; in cytokine regulation, the release of inflammatory cytokines, mainly the pro-inflammatory cytokines; antibody production, like the oligoclonal band productions, intrathecal synthesis. This is actually not though it is a diagnostic and something which has a prognosis, this is not necessarily the main way in which the B cells are involved in multiple sclerosis. And very important to note that especially in the progressive forms, the B cells actually are resident in the CNS in ectopic lymphoid structures underneath the meninges in the germinal centers, and this further drives the inflammation. In addition, it's also seen that diseases like anti-CD20 therapy and all eliminates the CD20 positive T cells also, and they also lead to T cell activation and proliferation via B cell activation. So what is the best time for initiation of disease modifying therapy? We have been mentioning all over that CNS inflammation is present right from early disease. The early inflammation is by peripherally activated immune cell, and the early phase of progressive forms with CNS resident inflammation. So these two phases are the phases in which they are potentially amenable to therapy if started early. So some data, some major trials which have come across recently from 2017-18 on the importance of early treatment initiation in the clinical course of multiple sclerosis. This was a study published in 2017 in which they categorized patients retrospectively into three groups. The one in which the treatment was started within 1 year of diagnosis, 1 to 3 years of diagnosis, and more than 3 years of diagnosis. What we are seeing is the Kaplan-Meier curves. The risk of progression to MS, that is the worsening in the EDSS score, was more in the patients who are initiated on treatment later. So the odds ratio and calculation was that the risk of progression to EDSS score, that is a score in which ambulation becomes progressively difficult, is increased by nearly 7.4% for every year of delayed treatment after MS onset. So this was a landmark article which came across. Then subsequently in 1920, we had an article comparing the different disease modifying therapies, meaning the impact of different disease modifying therapies on whether the MS progresses later to secondary progressive forms or the degenerative forms. So this was a multi-center study which involved around 1,555 patients in 68 centers and 21 countries. And what they noticed that in comparison with early versus late treatment, so early treatment here was defined as treatment initiated within 5 years of disease onset versus no treatment. So the classical traditional agents used to have a glatiramer or interferon. So if you start treatment early, the risk of secondary progression is much lesser. And this curve actually widens with time passing. That is, it means that if you start treatment early, there is a reduced risk of converting to secondary progressive MS, with the difference versus no treatment increasing over time. Whereas if you start treatment, say 6 years after onset of illness, initially there might be a perceived benefit, but later the gap narrows down. That is, the benefits associated with later treatment waned over time, and after 8 years of initiation, irrespective of the whether you receive treatment or not, some of them actually progress to the secondary progressive forms. So again, a major study to indicate that early treatment is effective in multiple sclerosis. And when they compare therapies as a subgroup analysis in the same study, so your natalizumab, alemtuzumab, fingolimod and all actually are categorized as highly effective therapies. The initial platform or meaning the moderate efficacy therapies or your glatiramer are interferon. So the risk of SPMS was reduced by 34% in patients who received high efficacy treatment compared to patients receiving interferon. So this was also another important outcome from the study. And so the important thing is to choose the right DMT initially. And more and more we are being familiar, we have been practicing this for quite a long time, is that a limited disease activity in the first 2 years or 3 years of diagnosis of MS is actually a good prognostic sign. It's a clinical indicator that your disease is not a very aggressive form of MS. Fortunately, in India, etc., what we see is, at least in our center, we have been seeing a lot of patients with not a very aggressive form of MS. So this is how the different disease modifying therapies came into practice. Interferon, 1995, which is slowly going out of practice. You have the oral agents like teriflunomide, dimethyl fumarate, which came around 2013-14. Natalizumab, which was used for relapsing remitting highly aggressive forms, 2006. Again being widely used, but with the risk of PML, etc., and the other agents coming through, again it's coming down in practice. The other B-cell therapies like alemtuzumab and all, we have not mentioned rituximab here. It will be coming to a subsequent slide. So this is a recent study, it came in 2021 June, in which they found that early high efficacy treatment in multiple sclerosis is the best predictor of future activity. So here it's a retrospective registry in which they found that they categorized patients who had received initially a high efficacy treatment versus a moderate efficacy treatment, and found that if you start a high efficacy DMT as a first drug, the odds that your disease is under better control is almost 4 times higher. If you start it as a second drug, like what you call as escalation therapy, you start with a lower efficacy agent and then go on to a high efficacy agent, the odds for a high, meaning NEDA or a no evidence of disease activity comes down to 2.5. When you start it as a third drug, actually there was no significant difference between the two groups. And another important thing was that patients with a medium or high risk of disease activity were significantly more likely to achieve NEDA on a high efficacy drug as a first drug compared to moderate efficacy. So one of the take-home points is that you assess the disease activity, it is very severe, better to start a high activity drug very early into disease. One reason why I took this article is because it gives a score in which you can clinically assess severity, a clinical score for assessing disease severity, which has been lacking in practice. This is not a validated score, but this was a score which is used in the study, in which they categorize 7 parameters: age at diagnosis, gender, symptom at onset, multiple symptoms at onset. There's a multifocal versus a unifocal onset, multiple relapses before diagnosis, MRI findings at diagnosis, the number of lesions, as well as your EDSS. So this 2 points, 1 point. So whenever a patient has 1 to 3 points, they qualify as a low risk. 4 to 7 points, they qualify as a medium risk. And 8 to 14 points, they qualify as a high risk. So the patients with medium and high risk, definitely we should consider starting on high efficacy therapy. And the forest plots again show that with high efficacy agents like natalizumab and alemtuzumab, the odds ratio for reaching a NEDA at 1 year was much higher compared to your oral therapies like teriflunomide and dimethyl fumarate. Another point which is emphasized is that whenever you start these agents early, you give an aggressive approach first, their tolerance and compliance is much better when used earlier rather than as used as second or third agents. The infections which can occur, the leukopenias which can occur, very less when you start it very early, because you're very focused, targeting the disease quite early in a focused way. So what are the anti-CD20 therapies in MS? We have rituximab, which we have been using all over. Then we have ocrelizumab, ofatumumab, and oblixetumab. So you have to understand that rituximab is a chimeric molecule. So there is a risk of, with cumulative use, there could be anti-drug antibody which is formed. So that is why the humanized monoclonal antibodies had come up. And the humanized ones like ocrelizumab have a lesser risk of infusion reaction. Ocrelizumab, for all our residents, is a drug which has been approved for treatment in primary progressive multiple sclerosis. Again, there's a catch here. All these trials you should look with a pinch of salt, because these patients who had PPMS and ocrelizumab was used, many of them had an active phase of disease. So that could indicate why the drug eventually came through. And so it's better to act when the disease is having active. And what are the adverse events with anti-CD20 therapies? You have infusion reactions, hypogammaglobulinemia. So you're supposed to measure the gamma globulins, immunoglobulins at onset as well as during the course of treatment. Risk of infections. PML is very negligible compared to drugs like natalizumab. COVID-19, of course, is a risk because of B-cell therapies, but again, an emerging topic. And risk of cumulative cancers like breast and skin cancers over a long period of time. One other concept is that how much of penetration occurs in these drugs, all these anti-CD20 therapies. So this could be one reason why these drugs are not very active in the progressive forms of MS, where the inflammation is more central. They started early when the inflammation is more peripheral, probably they are more effective. So the key differences in anti-CD20 therapies, rituximab will be what is commonly used. So here we look at few things. One is whether it's humanized fully or it's a chimeric molecule. Rituximab is chimeric. The other things like ofatumumab, ocrelizumab, and all are humanized. So these medications, as we all know, started initially in leukemias, lymphomas, then came out to autoimmune diseases like rheumatoid arthritis, eventually came on to MS, so extrapolated to MS, and there is a lot of evidence for all these three products. So they have different epitope binding site. The mechanism of action is both by complement antibody form, meaning anti-antibody effect, antibody dependent cellular toxicity, as well as complement dependent activation that leads to lysis of the B cells, which cause the antibody formation. So as expected with the humanized molecules and the newer molecules, they have a lot of advantages, like ofatumumab, which is coming up in a meaning which has been approved in 2020, actually can be administered even at home because it's fully humanized. There is meaning it binds to a different epitope, so it is actually, it's like insulin, it's like an auto injector pen which can be given subcutaneously every 4 weeks at home itself. There's no need for any pre-medication, whereas rituximab, ocrelizumab, etc., we have to admit and give them pre-medications like steroids, antihistaminics, and they have a longer infusion time as well. So rituximab available in India, other rituximab, yes sir, available sir, available. They've been mainly used for refractory CLLs, refractory rheumatoid arthritis and all, but neurological scenarios they have been very less used. So rituximab, again, very important to note that especially when communicating with patients and all, it is still an off-label therapy, but still probably the most commonly used, either as escalation or as first-line therapy. It is very highly, meaning very highly effective. It actually qualifies when you do no direct head-to-head comparisons are available. But what we should remember is that what we are using is a biosimilar form of rituximab, and based on extrapolation from other studies as well as indirect head-to-head comparison between agents, the effectiveness of rituximab is actually very good, which we have been seeing in practice. It is highly effective in RRMS, there is no doubt, and even in the progressive forms of MS, it is mildly effective. We can't say that it is not effective. It has very less rates of discontinuation because it's only a once in 6 month kind of infusion, which over a period of time, patients need to take only once in 9 to 12 months. And we have a lot of safety data extrapolated from other diseases like rheumatoid arthritis. We have safety data from around 7 to 11 years duration, which actually found that the risk of infections, leukopenia, secondary malignancies, etc., very negligible if used in a proper dosage with adequate monitoring of your immunoglobulins as well as your B cells. And the reduction on the what you call ARR or the annualized relapse rate is significant with use of rituximab. It reduces almost from 1.27 to 0.25 at 6 months, and by week 72 it reduces to around 0.18. Again, a very important point which is not put across in many studies. So rituximab efficacy in terms of control of relapses and MRI activity was actually comparable to natalizumab and superior to the oral agents which are many people practice outside, like dimethyl fumarate and fingolimod. So these are all indirect comparisons, again, like taking the effectiveness from different studies and comparing them. So in no way is rituximab inferior. And actually the newer molecule, again, ocrelizumab, again, the rituximab has been proven to be non-inferior in terms of indirect comparison. And it is relatively safe. You can time your pregnancy because the time gap between your infusions is longer. So there are ways in which especially young females with MS can get pregnant while on rituximab. The most important reason why it's coming up here is it's very cost effective with the use of biosimilars. Like you could get away with something like 15 to 20,000 every year could be the approximate expenditure while using rituximab. So again, a lot of ethical concepts in the European Union as well as in US, whether meaning in the presence of all these higher molecules like ocrelizumab, ofatumumab, and the dimethyl fumarate, etc., can they prescribe for rituximab, which is actually still off-label when you have the other agents available. So a lot of countries in the European Union especially do advocate use because we have insurance paid treatments. So it has been meaning almost regulatorily approved in many of the countries. Actually, most of the trials on rituximab come from the Norwegian and countries like Sweden. So this is a newer molecule which you should be familiar from a theoretical perspective. Ofatumumab, again, initially used for CLL and for refractory RA, refractory CLL and refractory RA. It binds to a different CD20 epitope compared to rituximab and ocrelizumab. These two bind to the same epitope. So one of the advantages is that they tell that it has what you call a slower off rate. So the slower off rate means that your duration of B cell suppression and all is very less, but it has various advantages, as we mentioned, that it can be given as a auto injector pen, which can be given at home once every 4 weeks, etc. So there's no need for the patient to, just like subcutaneous IVIG, like the patients can take at home. They need not come to the hospital very often. So this is something which is attractive in that way, and this has also been approved for FDA approved for treatment of RRMS. We should be familiar with that. And the trials, what is the Asclepios trial, in which they compared ofatumumab with teriflunomide, the moderate efficacy oral agents. They actually found that the odds was almost 3 to 4 percentage in the first and second year in terms of achieving a better disease activity or a NEDA score of 3. And again, the proportion of patients achieving the NEDA score of 3 in the second year of treatment was 9 out of 10 in patients with ofatumumab, whereas it was only 5 in patients with teriflunomide. And everything, including the ARR rate, the inflammatory disease score, everything was better with ofatumumab compared to teriflunomide. So what are the other novel B cell therapies in MS, like inebilizumab, which actually is a anti-CD19 monoclonal antibody. Again, we are all familiar that it has been approved for treatment of NMO spectrum disorder. There are currently ongoing phase 3 trials in which we are also a part, in which it's being used in myasthenia gravis also. So anti-CD19 inebilizumab is also shown in some early trials to be effective in multiple sclerosis. Alemtuzumab, again extrapolated from rheumatology and hematology, it is an anti-CD52 which acts on mature lymphocytes. It has been proved to be a high efficacy treatment in multiple sclerosis. But again, it has a lot of side effects, including flare-up of autoimmune disease, viral reactivations, herpes and varicella, as well as risk of vascular events like ischemia as well as thrombosis. And another molecule which has been shown to directly act on plasma blasts. Like we all know, rituximab doesn't act on plasma cells. Once B cells mature to plasma cells, which eventually produce the antibody, that's like all your anti-CD20 therapies don't act on that. So this is something which acts on plasma blasts, which eventually produce the plasma cells, anti-CD28 molecules. So these are also newer molecules which are coming up. Just to summarize, how you categorize your disease-modifying therapies in multiple sclerosis: moderate efficacy, the interferons, the platform therapies, the glatiramer, which is actually a myelin basic protein mimetic, dimethyl fumarate, and teriflunomide. All these categorized as moderate efficacy therapy. It can be, as a take-home message, be used in patients with a low disease activity. Interferons, because of their need for almost 2 to 3 times weekly over a prolonged period of time, the tolerability, it's been very uncommonly used in most centers right now. Dimethyl fumarate and teriflunomide, because they are oral medications, they are attractive, could be useful in patients with very low disease activity. Low disease activity, again, we are measuring based on some clinical scoring parameters, as well as, if possible, better to get investigations like neurofilament light chain, which is coming up in a big way. The high efficacy therapies are what you call your fingolimod, which is a sphingosine 1 phosphate agonist, as well as cladribine. We are not very familiar with both of them. Your very high efficacy therapies are your natalizumab, alemtuzumab, ocrelizumab, mitoxantrone, which is actually one of the initial drugs which was used in progressive MS, which is actually a topoisomerase inhibitor, has a lot of cardiac toxicity, but it was being used in patients still around 10 years ago, very commonly, just like cyclophosphamide, it was used. And the other newer sphingosine 1 phosphate agonists like siponimod and ozanimod. So whenever you use drugs like fingolimod, siponimod, you do a intensive cardiac monitoring for these patients, because they're at a high risk of cardiac conduction blocks, mainly AV blocks. So it has to be done inpatient only. Natalizumab, as we all know, is a alpha-4 integrin inhibitor. There is a high risk of PML. So you have to ideally look for the JC virus titers as well as your antibodies serially when on treatment. And whenever you find that there is a risk of developing into PML, better to stop the natalizumab. But it's a very highly effective treatment for treatment of multiple sclerosis. One more other thing with natalizumab is that whenever you discontinue to some reason, there's a very high risk of rebound with natalizumab, which is very well described. So that also we should all be familiar about.
These are all FDA approved drugs.
Yes, sir.
So where do you put rituximab in this table?
Rituximab is purely off-label, sir. It will be, that's what, in indirect head-to-head comparison, it's actually as good as ocrelizumab is what is mentioned. So it qualifies as a high efficacy or a very high efficacy treatment, sir. But because of probably other issues, it's not come up, it's not got approved, because all these molecules which have come after rituximab have got approved. But a lot of data on multiple trials on.
There's no incentive for the
Yes,
company to do a
yes,
trial on
it's mainly pharma driven, sir. Exactly.
So you guys should do it. I mean, but we need so many patients.
No, sir, we have data, sir.
Scandinavian, all the registry is a
Rituximab.
that is very effective. A lot of data already there.
But any of the European guidelines are recommending?
Yes, sir.
The FDA is not.
Yes, sir, and it's approved for use also. Like even it's approved for use also. Even if a practitioner in Scandinavian countries, in European countries, prescribes a rituximab for, it gets approved because it has a regulatory approval, not a. So I'll be concluding with the take-home messages. So multiple sclerosis, because of complex interaction of immune cells driving the pathogenesis, there is some indication from the last 4-5 years that early initiation of highly effective DMTs, disease-modifying therapies, might be better. That is what, like we discussed, no, like escalation therapy versus early initiation of high-effective DMTs. So that this concept of time-limited induction therapy, in which for the first 2 to 3 years you start aggressively, monitor them actively, surveillance with the use of clinical MRI, as well as you treat to target, like you look at your memory B cells, CD27 or CD19, go by that and try to maintain a good disease activity for the first 2 to 3 years. And eventually, like what we are seeing in rituximab also, like over a period of after the first 2 to 3 years, you are able to achieve a good disease control. The disease is probably more quiescent and your requirements for the subsequent dosing is also much lesser. So this is a concept which is coming up in a big way. Very important to say that PPMS, which has been conventionally told that it's degenerative, not treatable and all, you have to look at these trials in much more detail. Like the only drug, as mentioned, is ocrelizumab. It's a humanized CD20, but that trial actually, if you look at it in closer detail, you find that many of those patients were young ladies who had, young females who had a very active disease. So if you treat the active forms of progressive MS also, there could be a significant benefit. All these trials could be having observational bias, because once into a clinical trial, patients are monitored more frequently. They get almost a different kind of care, access to care. So that's one point which needs to be considered. But overall, because you have a lot of specific and targeted therapies, and there is evidence that if you start early, you'll be able to probably de-escalate a little bit, and the tolerability is also much higher if you start more targeted early. So this would be one of the main things, that it would be better if you can start more targeted therapies early into disease. Thank you.
Ajith, practically, what proportion of your new patients end up on these therapies?
No, sir. Anybody with a moderate, like a moderate to high scoring a disease activity will be somebody with a severe ataxia or a brainstem syndromes. We are straight away